study and the experience of Coolmine. And that is, I guess, as my presentation would indicate, is does it really matter whether we're viewing addiction as nature or as nurture in either paradigm? What we're about, and certainly what Coolmine has evolved into, is an organisation that provides the best possible service to people with problematic substance use and their needs and their families. So I'm going to explore that with you this morning. Now, so Coolmine in more recent times has been referenced as a pioneering organisation in terms of implementing evidence-based practice. So I just want to this morning explore that with you. I'm going to talk to you a little bit about the TC, just the treatment model, the intervention. I want to talk to you a little on community reinforcement approach, why we brought that in, what the impact has been. I want to talk to you a little bit also about the evolution of our women's service and our high-risk family service, and finally present some research around that. But I guess in surmising and summarising, as I say, we've evolved down a treatment path that has a very pragmatic response to supporting people who are trying to seek service with us. And somewhere in there we have bridged, whilst recognising harm reduction and working within harm reduction services, we also have stayed true to providing abstinence-based services. Okay, so established in 1973, first residential treatment centre in Ireland, highly structured concept-based therapeutic community. I'll just give you a little reference to that in the next slide. Basically, it's a highly structured behaviour modification programme. At its core, the process for the implementation of the treatment intervention is community as method. So it's the participants, it's the community, it's the psychotherapeutic interventions within the community. Significant changes in the last 15 years, which has included in the mid-1990s, the opening of the female-only residential service, which to this day remains the only women's-only residential treatment service in Ireland, working with pregnant women or women with young children. So in terms of the therapeutic community, are people generally, you're familiar enough with the therapeutic community approach to addiction in general, or I'll share this. So we had democratic therapeutic communities and we had concept-based therapeutic communities. The democratic TCs are born from the mental health services and around the 1940s, 1950s. But basically the whole principle was to try and challenge the lifetime institutionalism that was prevalent within psychiatry services, going back to Maxwell Jones and the Henderson Hospital. Basically, the process was that the inpatients would become active engagement, and they would be given more agency in that they could basically question and challenge professionals about the care that they were receiving to reduce the why we dichotomy. Parallel with this process, and maybe a decade later, we also had concept-based drug-free therapeutic communities, and they were developed in the States. Synanon from 1958 to 1991 and Daytop. The concepts, models and practices that originated within Synanon still have a presence in the therapeutic communities of today. However, it is very, very fair to say that they were Synanon went on to become extremely controversial. There was questionable practices with encounter groups, confrontational, very confrontational behaviour, and almost a very cult-like sense and feel. Parallel with that process, in Europe, we started to see the emergence of the concept-based drug-free therapeutic community, and that was established within Phoenix in the UK, Phoenix House in the UK, which still exists up to this day. So the therapeutic community is a treatment for drug abuse and addiction, again, in existence for about 40 years. But they're drug-free residentials, and they use a very purposeful hierarchical model with treatment stages that reflect increased levels of personal and social responsibility. There's a strong peer influence in the community as method approach, and it's mediated through a variety of group processes to help individuals to learn and assimilate social norms and develop more effective social skills. However, little access for external research, as Liam referenced, and Sheehan too. There is a limited body of research about the effectiveness of therapeutic communities, and yet they were very much the main treatment programme internationally, the main residential treatment approach up and into the mid-1980s before that was challenged in any way. So, abstinence, again, it's a disorder of the whole person. The belief in the therapeutic community and the drug-free concept-based TC is that addiction is a disorder. Problematic substance use is a disorder of the whole person, not just the drug. The process is that the individual, the community and psychotherapeutic change happens. Abstinence was the only desired outcome historically, I would argue. They would focus on recovery goals, which would be changes in lifestyle and identities. And the only way to change and the only way to support people with problem substance use was to invite them in to learn or indeed relearn behaviours. In the mid-1980s, we've seen the introduction of harm reduction and the emergence of harm reduction policies, again including methadone maintenance, HIV/AIDS as well, changing client profile, and there was a significant funding shift, as Shane has referenced, to community-based responses, targeting people, targeting clients, targeting families that needed support in their local community. The therapeutic communities had to mature, and that included their integration with other treatment modalities. And that's where I've arrived to in our journey this morning with Coolmine. Coolmine had very low participant numbers. There was very low people. We weren't serving we weren't supporting people the way that they needed support. Completely juxtaposed to any harm reduction. Back in the 1980s, Coolmine in a very strong position, abstinence, and abstinence was the only way. There was non-recognition of complex presenting needs. There just wasn't recognition of, as Shane referenced to, housing, training, employment, recovery capital, community capital, social capital. There were staffing issues too. We had a lot of graduates who may not have been provided with any training or supervision. Instead, they themselves were relying on their experience, which had been at times very confrontational practices. So there was a whole question around validity, big time, and there was also a question around survival of Coolmine.